New Jersey just passed the law to mandate pneumococcal coverage for kids in school. Is that a good idea?
Well, again, every incremental increase in the recommended age will further decrease the burden of pneumococcal disease. We know we made a big dent in invasive pneumococcal disease by immunizing infants. There are still cases of invasive pneumococcal disease, including some meningitis, rarely in the older population. So all these recommendations are designed to further reduce the circulation of pneumococcus in the throat of children
And young kids make better antibodies than the older population use general rule. Is that true?
Than the elderly population?
Yes.
Correct, yes.
So it's better to get them younger?
It's definitely better to get most vaccines before. Actually, it's been shown with several studies, like with the chickenpox vaccine. After about 13 years of age, your immune system starts to decline. So you actually need 2 doses of chickenpox versus 1 dose before that. So you're best off immunizing young, healthy children who have...
Well, New York State is indicating we're very shortly going to mandate a second dose of chickenpox. It's highly recommended at age 4. Pneumonia was a disease, we hardly see it, we get it occasionally. And we're starting to hear that there's a bug becoming resistant, pneumococcus. It's in Europe. There's some concerns in this country. Is that true?
Well, if you're referring to the one strain that's not in the vaccine, which is also resistant to antibiotics, has caused not only pneumonia but also meningitis. That is true. That's pneumococcals.
Against it, they don't have it right now.
Yeah, they may revise the formulation of the vaccine to try to include that.
So pneumonia, in theory, can make a comeback.
Yeah, and as we've said, any infectious disease can make a comeback, and all it needs is emergence of a strain that way A is not in the vaccine, and B is resistant to most antibiotics used.
And bugs share its genetic code a little bit sometimes, and sometimes something mutates. And like the flu of 1918 was probably 2 flu epidemics, one mild, one major, but one more virulent. Hey, look, I know how to get them. You know how to spread them. They got together in the lung. Someone figured it out without electron microscopes. We have a fear today. So these bugs can mutate and spread. So, and we're running out of antibiotics, aren't we?
And that's what's happened with the MRSA.
We're running out of antibiotics, aren't we?
We are. And in fact, just again, yesterday, a report from New York and Boston of multi-drug resistant MRSA. So one that's no longer susceptible to clindamycin or to Bactrim is virtually untreatable unless you use vancomycin in the hospital. That has just emerged. So that's a good example of that. It's called MDR-MRSA.
Now, the theory, we're getting resurgence of these new superbugs. Sometimes doctors use antibiotics a little too free. Also, there's some indicator that some of the animals that we eat are fed antibiotics. So that's 2 causes. So we have to start rethinking. If you have a negative throat culture or a quick strep, why are you taking an antibiotic? If you have mononucleosis and maybe you want to do a culture to be 100% sure it's not a strep, it's negative, why take an antibiotic? Even in ear infections, there's a new thing called wait and see. The kids under 2, symptomatic, you treat. 2 to 3, it's veritable. Over 3, wait up to 3 days. And many times, 60% of the time, it's viral. It gets better without any treatment, and it goes away. Is that true?
Absolutely true. And I strongly believe that we don't practice our art true to our name. Specifically, the word doctor means docere from Latin, which means to teach, right? We are the teacher. It's our job to spend that extra few minutes teaching the parent about the viral infections that do not respond to antibiotics. And like you said, the majority of what the pediatrician sees is viral infections. It's our job to talk rather than to pick up the pen and just quickly prescribe an antibiotic.
So a doctor should educate and keep a good line between his patients.
That's right.
Sometimes you have to reevaluate him in a day or 2. But that's wait and see is going to become the in, not the out of way of practicing.
And that's our responsibility rather than being irresponsible and abusing antibiotics, because in the end it's going to be all our fault.